Good afternoon, everyone. So my topic is the advanced strategies in improving outcomes during mechanical ventilation. I'm a PhD student at the Department of Anesthesiology and Intensive Therapy. And with my team, we phrased a vision as implementing personalized strategies in intensive care medicine on a broad scale, hence providing more effective and safer interventions. Our mission is to help disseminating scientific-based medicine in anesthesiology and intensive therapy. I would like to talk about three research I've been worked on. The first is the effects of individualized versus conventional Peep settings on perioperative outcomes in patients undergoing abdominal surgery. Peep stands for positive end-expiratory pressure that we use during general anesthesia to improve oxygenation by keeping the alveoli open. But a high level of this pressure may also cause harm by overstretching the lung tissue. And here comes the individualized setting. We questioned whether those patients who underwent abdominal surgery had a better perioperative outcome that used individualized Peep compared to those who received a fixed Peep setting. We were interested in the incidence of postoperative pulmonary complications as the primary outcome. We have conducted our systematic search and we found 18 articles eligible for data extraction. I would like to present our primary outcome, the postoperative pulmonary complications. These included atelectasis, pleural effusion, pneumonia, and we can see the number of patients who developed at least one of these complications in each group. You can see a slight heterogeneity, which is due to the fact that the included studies were both conducted on patients who underwent laparoscopic surgery and on those who underwent open surgery, as well as the population were sometimes obese patients and non-obese patients. Regarding this outcome, we can see a tendency to favor the individualized Peep, as there were about 50% less incidence of postoperative pulmonary complications. However, this result is not significant. The PF ratio is a very useful tool to monitor oxygenation. This can be counted as the partial pressure of oxygen over the inspired fraction of oxygen. And if we look at the healthy people's value and we divide these numbers on the left, we can get another value, the PF ratio. If this value is between 300 and 500, then we consider it as normal. But the decrease of this ratio means a more severe hypoxemia. So we created subgroups of our studies, and we found that the PF ratio was significantly higher in the individualized group. However, there was only one study, on the very top, the Van Hecke, that was the only one that favored the fixed Peep. We did a leave one out analysis, and by leaving that out, even that subgroup turned into significant. And the reason we allowed ourselves to leave this one out is that because this was the only study where the control Peep, the Peep, was relatively and unusually high, and also it was higher in the fixed group compared to all the other studies where the individualized Peep turned out to be higher than the fixed setting. So we thought that the higher PF ratio in the individualized groups may be due to the fact that these patients received a higher Peep value. The next important thing is hemodynamics. During general anesthesia, we have to consider that the mechanical ventilation will cause a hemodynamic instability. And if this happens, even vasopressors may be required to maintain the stability. So we collected the number of patients who received vasopressors during the surgery. And as we can see, this outcome tends to favor the fixed Peep, as there were about 52% more vasopressor use in the individualized group. The next is lung compliance, which is the change of volume over the change in pressure. And this means that a higher compliance means that less pressure is needed to fill the lung in order to achieve a higher change in volume. We had an elevated lung compliance in the individualized group, and it was significant. Now, regarding the other two outcomes, neither the length of hospital stay nor the hard outcome, the 30-day mortality, showed any difference between the two groups. As a conclusion, we can say that the individualized PEEP setting seemed to reduce the incidence of postoperative pulmonary complications, and it resulted in a better intra and early postoperative oxygenation. And it may also lead to a better lung mechanics, which was represented by the compliance. But we have to consider a higher chance of hemodynamic instability. As a summary, I would like to highlight the strengths, as we only included randomized controlled trials, and this would be the first meta-analysis on individualized PEEP titration in patients undergoing abdominal surgery. As limitations, I would like to mention the heterogeneity of both the populations and the different types of surgery, as well as the intervention, because different studies used a different titration method, and even the control group used a different value, as well as there were differences in the time points of measurement. As an implication for practice, it would be improving oxygenation and reducing postoperative pulmonary complications by personalized ventilation settings. Implication of research would be to perform further studies on a more heterogeneous, homogeneous population, and regarding the population and the types of surgery, as well as to have a consensus on what kind of equipment and how we should titrate the PEEP, and where should we measure the outcomes. As my next topic, I would like to talk about an initiation of a registry on acute hypoxemic respiratory failure. This is important because it is a leading cause of need of admission to the ICUs, and it is associated with a very high rate of mortality. However, we still don't have any registries, neither in critical care in general, nor in this topic in Eastern Europe. So this is the reason we would like to collect high-quality data on outcomes and standards of care. Here you can see our current resources of the registry, and we are planning to start a pilot registry in Florence Hospital. We have already defined our eligibility criteria, and we are currently working on the questionnaire. My third topic is hemoadsorption therapy in ARDS patients. This is also going to be a systematic review. ARDS is usually a secondary cause of another illness, and it is associated with a hyperinflammatory condition. This is why hemoadsorption, which can reduce the level of cytokines in the blood, may be beneficial for these patients, and we would like to investigate the outcomes, the oxygenation outcomes and ventilator associated outcomes of those who received hemoadsorption therapy. The research implication of this systematic review would be to summarize the current data on this therapy in ARDS patients, and therefore help clinicians in decision-making and further research. We have already conducted our systematic search, and we are currently in the full text selection of this topic. So these were the three projects I've been working on, and I would like to thank your attention with this quote. It is spring again, the earth is like a child that knows poems by heart, by Rilke. Thank you.
Thank you for your presentation. I just want to ask, one of your outcomes is hemodynamic instability. And I am working on a project regarding hemodynamic instability. How would you define hemodynamic instability? Did you find the same definitions in all the articles?
There were no definition of the hemodynamic instability in the articles. It's just something we have considered as another outcome to measure, or another status, because they all reported the amount of vasopressor use. And this is something we've considered as an extra thing that worth investigating.
Thank you very much. It's a very interesting project, and so I have a question. Is there any contraindication for this procedure?
Since the titration method itself often requires a much higher pressure in the beginning of the surgery, then maybe it wouldn't be as useful in those who are in a previously very bad condition and have a higher chance on the base to develop some complications, because the Peep itself can be one thing that is responsible for hemodynamic instability. But other than that, I would only say that those who are contraindicated to go under general anesthesia in the first place.
I have a question, because we've been thinking on this registry, like going international. Mm-hmm. So, and then we received a very good comment recently that it may not be a good idea. So what are the pros and cons of going international or keeping the registry in Hungary?
Well, the pros are definitely the more data from more countries, but also since we are trying to collect data not only on outcomes but on the standards of care, then only doing a registry, for example, in our country probably would show us a more true picture of the current status in our country, and we could focus on our problems that need to be solved. This is what I would.
So representativeness is the key word here.
Yeah.
Yeah.